Hello, I'm just curious if the room can hear me.
Thank you all very much for making the effort to be here this afternoon for our very first cost growth benchmark initiative reveal. I know it was a challenge for many of you who drove from far away and rearranged your calendars. So appreciate it and really are looking forward to and the conversation this afternoon. Thank you, Governor Lamont, for joining us. Making some remarks shortly. So the order of business this morning is I will start out and give you just a couple of top line results from first of their cost growth benchmark report. Then I will invite the governor to make a few remarks. We will have public comment, and then our public David House will walk through a really extensive set of slides with more detail about the cost growth report. If I could, I would like to say a few thank yous. Today's meeting is the result of 3 years of work. The governor and I right before the pandemic started, where he signed Executive Order number 5 that started this work in February of 2020. So I'd like to thank all of you for your engagement in the process. We could not have done this work without the input of the state, and you had many predecessor committees, and so I want to thank them as well. I'd like to thank the OHS team who's been they're lined up over here. They've been working very hard to bring this project to fruition. Our colleagues at Bay Health and Mathematica who've been supporting us on the analytics side. I'd like to acknowledge my predecessor, Vicki Beltry, who got this project in motion and really put it on solid footing. And I'd like to thank the governor and the governor's office for their support of the initiative. As we all know, this report and this work is all about making healthcare more affordable for the residents of Connecticut. As a former practicing provider, I still remember to this day the hardest part of my job was sitting down with a patient and trying to help her figure out how she could afford the care that I was recommending that she had. So this is all about working towards that goal, making healthcare more affordable. And as you've heard me say and the governor say, we will only solve that very significant, complicated challenge if everyone is part of the solution. And that's why we're so grateful for all of you for participating in this work. So if we could move to the results. Just as a refresher, you will recall that we have set 5 years of cost growth benchmark targets. This year, we will be reporting the changes in healthcare costs between 2020 and 2021. And our benchmark value for that year was 3.4%. It goes down to 3.2% and then down to 2.9% for the final 3 years of the initiative. And as you all know, benchmark values are based on a blend of forecasted per capita potential gross state product and forecasted growth in median income. So today we're looking at if we meet the 3.4% growth target for 2020. Next slide. I went through Executive Order 5, back 22-118. Also, in addition to the healthcare cost growth benchmark set targets for so how much of the total spending did the state aim to spend on primary care? We know that primary care spending is associated with better outcomes and lower overall costs. So the state has set targets for 2021 of 5% and slowly going up to 10% of overall spending by 2021. Next slide. So these are the top line results. In 2020 to 2021, statewide healthcare costs grew 6%, exceeding our 3.4% benchmark. There was quite a bit of difference between markets. Commercial healthcare costs grew 18.8%. Medicare costs grew at a much more modest 1.4%, and Medicaid at 0.8%. All 5 commercial payers exceeded the 3.4% benchmark for the 2021 year. 3 out of the 4 Medicare Advantage payers exceeded the benchmark. And we also will be reporting by advanced network, meaning provider groups, and we will be adding that reporting. We won't be talking about it today, but adding that reporting to our final report, which will come out in this week. Next slide. On the primary care side, we did achieve our target of 5%. Primary care spending was 5.1% of total spending in 2021. Medicaid exceeded the target of 8.3% of total spending on primary care. Commercial spending 3.9%, Medicare Advantage 3.5%. So the statewide average was brought up by the Medicaid spending on primary care. 2 of the 5 commercial payers achieved the 5% target, and none of our Medicare Advantage payers achieved that target. I think that's it for the results. Next one. So with that, top line findings and with a focus on
right. You hear me? You want the mic? I'm not like to see my mic. I just Because I live in the state, been doing this about 4.5 years. I have a lot of friends here I get to talk to, but often one-off. So Deirdre said maybe we should get together. I love it. I don't know why Connecticut is not best in class. We got the best damn hospitals in the country, incredibly innovative. I got a pharma right here producing some of the most extraordinary out there. We're the insurance capital of America. I feel like we got the pieces of the puzzle. We're a relatively small state, and yet I feel like I'm always playing catch up. And Deirdre just showed numbers where we're not meeting the benchmark, and she explains we're going up, faster in terms of healthcare costs than a lot of our neighboring states. It's not just a national trend. And so what I've got to try and figure out, we all share the same goal, I think, make it more affordable, more accessible, and be a leader. I just don't think we're getting there. So when I talked to Deirdre a year ago, we're thinking about our legislative session, and I said, let's come up with some ideas that we think that actually I come out of small business. We get hammered. We have absolutely no negotiating leverage at all. I know from families what it means to them in terms of healthcare. More of those costs being pushed over there. And so I tried sort of one off. We got all the great pharmaceutical guys. They all come in. They say, don't blame me, blame the PBMs. Okay. Hospitals will all tell me we're getting hammered on Medicaid, we're just cost shifting around, don't blame us, we need more subsidies for this, we'll be better off. And, everybody wants the taxpayers to take over the health insurance industry in the state. I thought that was not the smartest idea I ever heard. But you can see why there are a lot of ideas out there right now. So that's why we're convened here to hear your best thoughts. And hopefully go beyond just having us continue to subsidize things until we, move away from a fee-for-service or, do more preventive stuff. I heard married to healthcare for us. I've been hearing this for 40 years. So a lot of the ideas that Deirdre and the team have come forward with, if you have better ideas, let me know what it is. Tell me, everybody hates the facilities fees if you're in the hospital. Okay, well, leave that private clinic alone, then they don't have to pay, a facilities fee. Why isn't that good for us? We're trying to go out and buy pharma. Deirdre's talking to 10 of the states right now. I think everybody's okay with this, but tell me if I'm wrong, where we can start getting a little bit of purchasing power. See what we can do on behalf of consumers. And then we get a drug discount card to make sure when you go to the pharmacy, you get the best opportunities there. These are some ideas that seem to be real to me and make a difference as we plan more strategically. But let's say nobody likes these ideas. So give me better thoughts that make a difference, in the near term. Because I know every day, given my job, what it means to small families, what it means to small business, what it means to the taxpayers of the state of Connecticut. And I'm fishing around. And finally, part of the benchmarking I like, and what we started with Kevin Lembo some years ago, is see what the relative costs of things are, say in terms of hospitalizations and as well as pharmaceuticals. And in my business, you win a bid when you're 8% less than somebody else. I kid some of the hospital guys. I mean, here is dramatic. You'll have a 60, 70% differential. What is going on? Some hospitals get, 120% of Medicare, some get 300% of Medicare. So I can't figure out how this market works. I've come forward with some proposals, but we're here at the table because I want to work it together. And, Kathy said, look, let's stay collaborative. We talked just this past weekend. And that's one of the reasons here. I'm coming up with the best ideas I think can help make a difference for more affordable, more accessible healthcare. If you got some better ideas and ways to refine this, let me know. And I think that's what we're doing with it. And I'm here for a bit.
Thank you very much, Governor. So we're going to move on to some business quickly, Governor. feel free obviously to speak out when you speak out. First is to approve the minutes of our regular meeting. So could I have a motion to approve the minutes of the regular meeting? So moved by Alex Barr, do I have a second? Sarah, thank you. Any discussion? All in favor, please indicate by saying aye. Any opposed? Any abstentions? Okay, the motion carries. We are going to, I think, move on next to public comment. Anyone online wants to make a public comment?
Yeah, well, if they would comment, they can press the raise hand button and
If you're online and you want to make a public comment, please press the raise hand function. Ready in the room? Nope. Yeah.
I'm not seeing
You can start on. Start now. Thank you. If you're on the phone and you're not on Zoom, and you want to make a public comment, press star nine.
Hi, it's Susan Millerick. First of all, greetings to everybody in the room. And it's so great to see you here, Governor. And I really feel like we have lots of progress we can make in the year ahead. So I'm excited to be here, and I don't have any comments on the agenda or the minutes, but I wanted to say that.
Thank you, Susan. You just popped up on our screen. That's
There you
great. All right. Since we have no public comment, we're going to move on to the heart of our discussion. And I'd like to start. Grace.
I don't think so, but you can look in the desk drawer behind you.
Can I just ask, well, we're all here, anything you want to accomplish in this meeting and beyond? And I think you heard sort of the broad frame of what I'm thinking about, just before we go through the dissertation. If there are any thoughts and things you want to share to help us focus, I'd love it. Otherwise, we keep going with the agenda.
Well, Governor, I will pick up from the. Sure, Chris O'Connor. I will say that that there's obviously a lot going on, and appreciate the fact that you see it from everybody's individual lens, and that obviously conveys a sense. And I know from the perspective is that maybe the hospitals are crying a little foul with what's on the table. I just want to echo the collaboration component that I think Kathy, you mentioned, Kathy talked about. We really do want to be part of a solution. And I know it feels that we're constantly coming back and saying, you're going to harm us. We have concerns about timing, maybe coming out of COVID. For us, maybe we're in a very unique position where we're losing money for the first time in a long time from operations, and that puts pressure on us that probably amplifies some of that concern. But at the end of the day, we know we have to be part of the solution. I just want to continue to reinforce the importance of working together at solutions. And while the finances are always challenging, I think we definitely, from an industry perspective, want to be at the table and contribute, because you're 100% right. From an ideal perspective, we all want to reduce the cost to the consumer. And I think there are ways to do that. And we certainly want to be part of that. But one of the challenges of the industry, we have no governor over utilization. So when you look at benchmarks like this, and we've seen it in the data that OHS has presented as, our utilization continues to rise. Well, it's not all good utilization, so we need to work together to find ways to find more cost-effective solutions. And I just wanted you to hear how important that is from my perspective, from I think the field's perspective, and continue to support that effort.
Good afternoon, Governor. Thank you for the opportunity to address our concerns. My name is Angela Harrison, Phillips Health Ministry here in Hartford, Connecticut. And I would really love in all the cost reduction efforts that we would stay laser focused on health equity here in the state of Connecticut. And all that we do, if we can maintain quality across all communities, and true access to the quality institutions that we have here in the state of Connecticut for all residents. We should not have a life expectancy gap of 15 to 20 years between our suburban towns and our urban centers. So 15 to 20 years of life difference in Westport to Bridgeport or West Hartford to Hartford. We really need to deal with that. And all that we do, all this brain power in this room, we should be able to accomplish that. And I look forward to making that happen.
Anybody else before we start?
Hi, everyone. Can you hear me okay? Hi, everyone. I'm Grace Clary. I'm a consultant at Bailiff Health, and I support OHS in its cost growth benchmark and primary care spend target initiatives. I'm going to be kicking off our presentation today, which will be in two parts. First, I'll provide a bit of background on the cost growth benchmark and OHS's process for collecting data to measure performance against the benchmark. And then I'll turn it over to my colleague, Michael, who will be diving into the results of our analysis today. First, a reminder about what it is we're measuring against the cost growth benchmark. We're looking at year-over-year growth in total healthcare expenditures. Total healthcare expenditures comprise two things: total medical expense, which is spending on all medical services for covered residents. And by covered residents, I mean Connecticut residents who get their coverage through Medicare, Medicaid, and commercial insurance. The second component is what we refer to as the net cost of private health insurance, or NCPHI, and that is spending for private insurance administration. It's what we typically refer to as the margin or the profit or loss associated with insurance administration. These two components, total medical expense, or TME, and net cost of private health insurance, or NCPHI, is what we look at when we're talking about statewide growth against the cost growth benchmark. This slide shows the other levels at which OHS is assessing and reporting performance against the cost growth benchmark. OHS reports total medical expense at the statewide level, at the market level, meaning for commercial, fully and self-insured, Medicare fee-for-service and managed care, and Medicaid fee-for-service markets. You have all seen state and market level results for the cost growth benchmark before. We shared this with you for the 2018-2019 pre-benchmark period last spring. And then for the first time this year, as Dr. Gifford mentioned, OHS will be reporting total medical expense trends for insurers and for advanced networks stratified by market, assuming those insurers and advanced networks have enough attributed lives to be reported publicly by OHS. Now, I want to take a minute to discuss this term advanced network that we'll be using today. And again, we won't be reporting results by advanced network today, but they will be included in OHS's final report on Friday. Advanced network is OHS's term for large provider entities that are large enough to participate in value-based contracting, whether or not they do so. For the 2019 to 2021 period that we'll be discussing today, OHS collected spending for a list of 30 advanced networks, which they selected based on a survey and conversations with insurers about their contracts. OHS asks insurance carriers to report spending for all lives attributed to advanced networks for the performance year for commercial and Medicare Advantage business. And for Medicaid fee-for-service, DSS reports Medicaid spending based on practice organizations' participation in the PCMH program. Also, feel free to stop me and ask any questions along the way. I know this can get a bit mean.
Yes, and if you raise your hand, I will come and bring the link to you.
The data you'll be seeing today was collected from several sources. Most of the information comes from insurance carriers, from aggregate spending data on the commercial and Medicare Advantage spending markets. OHS also requests Medicare fee-for-service and Part D spending from CMS and Medicaid fee-for-service data from DSS. To calculate the net cost of private health insurance, OHS uses a combination of insurer-submitted data and publicly available data from reports such as medical loss ratio reports. And finally, OHS also requests spending data from the Veterans Health Administration, as well as from the Department of Correction, to be included in the statewide expenditure figures. As I mentioned, the bulk of the data comes from insurance carriers. OHS requested that carriers submit data in August of last year, and for the past 6 months, OHS and Bailiff Health have been validating and analyzing the data, and we've asked for multiple resubmissions from insurers to ensure, to the best of our ability, that the data are valid and complete. The results we'll be presenting today reflect two main methodological changes from what you may have all seen in the past based on your recommendations to OHS. These changes were both designed to give us more confidence in our assessment of insurer and advanced network performance. The first change is truncation of high-cost outliers. We have set truncation thresholds at different levels for commercial, Medicare, and Medicaid spending, and we did not include any member-level spending above these thresholds when assessing insurer and advanced network performance. Truncation was added to prevent a small number of high-cost members from having a disproportionate impact on insurer and advanced network performance. We also replaced clinical risk adjustment with standard age, sex, risk factor adjustment. This change was made to ensure that risk adjustment is done to reflect the gradual change in population rather than any improved documentation of patient condition on claims. These methodological changes, truncation and age, sex, risk adjustment, are in line with the methodologies of other cost growth benchmark states.
Excuse me, just as a follow-up to this, can we just get the numbers associated with the truncation of how, I know you broke it down by different payers?
Yes, so for the commercial Medicare Advantage markets, member spending or the truncation was set for member level spending at $150,000. And for the Medicaid market, it was set at $250,000. And if you'd like to ask a question, just raise your hand and we'll bring a mic to everyone. Any other questions on what I've discussed so far before I move on?
Hi, I do. Yes, I'm sorry. Susan Millerick. How many states in America have such, benchmarks or so on, this kind of work going forward? I know there's a few in New England, but I was curious to know that information. Who else is doing this?
Right. So Connecticut is one of 9 states that have been pursuing cost growth benchmark strategies. Some in New England, such as Rhode Island, Massachusetts, and New Jersey. Others more recently, such as Washington, Oregon, Nevada, and California.
And which is the most mature? Thank you. Which is the most mature of those?
That would be Massachusetts. Theirs was established in 2012, or the legislation was established in 2012.
Thank you.
All right. I want to make a few notes about the findings before we move into the results that are important to keep in mind First, just a caveat, because I know that we presented other data and analyses to this group in the past, most recently APCD Medicaid and commercial analyses as recently as last month's meeting. I want to note that the cost growth benchmark data you'll be seeing today are different from APCD data in some important ways. The cost growth benchmark data include non-claim spending, spending on the self-insured population, and pharmacy rebates, none of which are in the APCD. And this is one of the primary reasons that OHS collects cost growth benchmark data in order to have a more comprehensive view of healthcare costs in Connecticut. And for similar reasons, we would caution against comparing these results today to any other publicly available results you may see on Connecticut's healthcare costs because of different methodologies and inclusions and exclusions. I also want to note that this is a unique reporting year because we'll be presenting on 2 trend years, a cost growth from 2019 to 2020, which is still the pre-benchmark period, and then from 2020 to 2021, which is the first year that the cost growth benchmark and primary care spend targets apply. We're sharing both of these trend years, even though there was not an official benchmark or target until 2021, because we think it's important to show 2020 spending to provide context for 2021 benchmark performance. But in the future, please keep in mind that OHS will only be reporting on 1 trend year annually. On that note, we cannot talk about spending in 2020 or 2021 without mentioning COVID-19. 2020, as you all know, was a highly unusual year, both in terms of utilization and in spending. Utilization was down significantly when offices were closed and elective procedures were deferred. And at the same time, there was a huge infusion of federal dollars into our healthcare system to help prop up healthcare infrastructure and help support providers through the pandemic. These federal payments are not included in the cost growth benchmark data, but there are estimates that show that healthcare spending actually did increase in 2020 by about 10%, driven by this increase in federal payments. In 2021, as you all know, we saw utilization and spending rebound as services returned in person, reaching or sometimes exceeding pre-pandemic levels. And we see both of these trends, the reduction in utilization and spending in 2020, the rebound in 2021 reflected in the cost growth benchmark data, with many more entities exceeding the benchmark in 2021 than we might expect under normal conditions. And Michael will be noting how we see this in the data when he presents the results. Finally, there are a number of cost growth benchmark reporting dates that I just want to flag and which OHS is statutorily required to meet. As I mentioned, data were submitted last summer in August. This month, OHS is reporting on the results, including posting the written report with advanced network performance by the end of this month. By May, OHS will identify any entities that significantly contributed to the state exceeding the benchmark. By the end of June, OHS will hold a public hearing on the results. And then by the end of October, OHS will report trends and recommendations to the General Assembly. So that's a timeline of where we are now and where OHS is headed. And that is the end of our methodology deep dive and context before we dive into the results. Are there any questions on anything that I just discussed before I turn it over to Michael to get to the fun part? All right. That.
Good afternoon, everyone. So nice to be with you and in person for the first time. So I'm going to walk you through the results in detail. I got a preview previously from Deidre. All right, so I'm going to start by reviewing what spending looked like in terms of growth and total spending for 19 to 20 and 20 to 21. So this graph depicts the trends that Connecticut experienced in total healthcare expenditures. So there was that decrease of 3.1%. I'm going to reference on a few occasions what was happening in neighboring states because I benefit from having access to data from Massachusetts and Rhode Island. And so obviously neighboring comparative states are helpful here. What those two states saw, and I will note some of this information, particularly for Massachusetts, has been made public, the Rhode Island information not yet. But having reviewed both, I can tell you that the decline in 2020 was comparable across the three states. In fact, almost identical. The trend in 2021 was not comparable across the three states, including by market, and I'll be sharing the by market trends a little bit. What we did do, because it seemed appropriate, was we calculated an average increase over the 2 years, because with that unusual drop in 2020, we knew that there was going to be a higher than average increase in 2021. So when we averaged the two, and this is not for benchmark purposes, because the benchmark is set for 1 year, but just to give some context, it was 2.7% average. But technically, when we apply the benchmark, we're applying it only to 2021, and that's the 6% growth. Okay. When we look at aggregate spending, healthcare spending in Connecticut in 2021 was $34 billion. And you can see the breakout here by market. The commercial market is the largest portion of spending. It's also the portion of the total spending that is growing the fastest. You can see at the top those little slivers. The purple sliver is insurer administrative costs and margin, a relatively small part of total spending, and even smaller those other public sources. So that's Veterans Health Administration, Department of Corrections health spending. Little focus on the net cost of private health insurance. This is a particularly volatile category of spending because insurers' profits tend to move about quite a bit from year to year. That definitely happened in 2020 and 2021. So in 2020, in the insured markets, insurers' profits grew because of the unexpected drop in utilization. Conversely, in 2021, those margins shrank because utilization went back up. And so you can see here in this graph that for the self-insured net cost of private health insurance, it didn't change a lot over the 3 years because self-insured payments are not paid the same way that they are in the insured market. But there's a lot of volatility here in the insured markets. For example, large group went from 0.24 to 0.34 to down to 0.18. So a lot of volatility there. And that's why when I'm going to share data with you later today, I'm going to focus on total medical expense, which pulls out insurer profit and margin because of the volatility of this category. So when we focus on total medical expense, we're only focusing on spending for services. And as Ray said, I will say too, if you've got questions at any point in time, please feel free to raise your hand. All right, so now I'm going to talk about total medical expense by market, and then I'm going to start with an overview across the markets and then focus on each market. So on the left, we see what happened in 2020. There were declines across all three markets, largest in Medicare Advantage. Now, these percentages are different than what you saw for total healthcare expenditures because we peeled out admin and margin. So that's why the numbers are a little bit different here. On the right side, we can see what happened in 2021. And there's that overall spending grew 8.2%. So that's greater than 6 because we pulled out the admin and profit, which declined relative to 2020. And it's almost, or it is really all commercial market spending, 18.8, with Medicare and Medicaid both being very low, both below 2%. And I'll explain a little bit what was going on in Medicaid that made Medicaid particularly low in 2021.
Michael.
Yes.
And DJ Gifford, Office of Health Strategy. I just, everybody knows this, but I just want to say it out loud because I've had to remind myself multiple times. when I was reviewing these slides. This total medical expense is not price. It's a combination of utilization and price, right? So we're not separating out how many more services or fewer services or how much the price went up or down. It's a combination of utilization times price, and that's the total increase that you're talking about.
Right. We cannot distinguish the role of price and utilization in these data. We can when we do the all payer claims database analysis. So at our last steering committee meeting, we shared with you updated analysis through 2021 that broke apart the role of payment per unit, which is really more accurate than price. Payment per changes in payment per unit, changes in utilization. I may share with you some information from that analysis to help interpret this, but the benchmark data only give us total spending and do not allow us to distinguish the roles of those two factors. Okay, so I want to give a little bit of a comment. Actually, I'm gonna wait till the next slide too. So on that 18.8%, because obviously that jumps out at us. So here's a focus just on the commercial market. We can see the modest drop, minus 3.4%, and zooming up to 18.8. That averages to 7.5% per year for the 2 years. That 7.5% is not out of line with what we've seen in the all payer claims database analysis going back to 2015. What's unusual here, that 18.8% is it is significantly higher than what occurred in Massachusetts and Rhode Island in 2021. I don't know all the reasons why, but I can tell you that it is quite a bit higher than either of those two states. You'll note that I said earlier that the drop in 2020 was about the same across the two states. So it's not that Connecticut dropped at a different rate, but the bounce back or the bounce up was much higher in Connecticut than those states. I'll also note that I have data from a couple of states in the West, higher than the states in the West too. I don't know the reason why, but I observed that that's a notable difference. Okay, so this is the commercial market. In the Medicare market, we had a very modest period of growth in 2021. So over the 2 years, Medicare is actually trending negatively for these 2 years. And here we are including both Medicare fee-for-service and Medicare Advantage. So this is really the full Medicare market. I'm not sure why the spending growth in 2021 was so much. Paul?
Yeah, I think everybody can hear me.
Sorry, please, online they can't.
Yeah, the online people can't.
We can.
So could one issue be the age of the population, right? So you have a commercial market, you have younger people coming back and bouncing back for elective surgery in 2021, not as apprehensive as the population that covers Medicare. Were they still resistant to coming back into the hospitals, still COVID related? Younger people, maybe less. I'm just throwing that out as a potential, because it just doesn't, the data doesn't add up in the commercial market versus Medicare. It doesn't make sense that we have that big a bounce back in utilization of services in the commercial market versus Medicare.
Yeah, you could be right. I just don't know. When I look at what happened in Massachusetts and Rhode Island, it doesn't help me because Massachusetts had a much higher rate of growth in 2021 in Medicare, and Rhode Island did not. Rhode Island actually had a decline. So that makes sense, Paul, but I can only speculate. Okay, and last, in the Medicaid market. Yeah, I'm sorry.
Yeah, sure. Kathy Smart, Stanford Health. What happened with Medicaid in Massachusetts and Rhode Island?
Well, so Medicaid's the next slide.
Okay.
So let me share that with you. So we can see here, Medicaid went up just a little bit. Medicaid in Massachusetts also went up just a little bit, and it also went down just a tiny bit more. So what are we seeing here with Medicaid? We are seeing a little bit of an artifact, because during the public health emergency, Medicaid redeterminations were suspended. And so the population covered by Medicaid grew significantly. In Connecticut, Connecticut added 40,000 lives in 2020 and 108,000 lives in 2021. I can't confirm this to be the case, but there are many who believe that people who became eligible and enrolled for Medicaid in 2020 and early 2021, when the economy was cratering, subsequently gained employment and employment-based coverage in 2021 later, and they began using that coverage. So there are many who believe that there are a lot of people who were covered by Medicaid who were not actually using Medicaid services, which accounts for very modest spending growth in all three states. In all three states, we're talking either a little bit of growth or negative growth. I think, as you're all aware, the public health emergency for the Medicaid program and the suspension of eligibility redeterminations is ending, what, in 4 days? So I think after that, we will see some return to normalcy in the calculations, but we are likely to see depressed trends in Medicaid continuing through 2022, if that hypothesis is correct. Guy, anything you want to say?
He will send DSS Medicaid director. The only thing I'll add is that the flip side of what you just said means that going forward, we'll probably see a bit of an increase in Medicaid spending mechanically as those lower cost individuals leave. So just for next year, let's keep that in mind.
Yeah, actually, it might not show up until 2023.
Sure, next 2 years.
Yeah, right. Okay, so obviously we have three very different tails if we look across commercial Medicare and Medicaid for this time period. Okay, so now I want to share with you what was going on at the service level. So when payers submit information, they submit it in large service categories to give us a little bit of insight to what's going on. We can only get greater insight by using the all payer claims database data, but we get a little bit of insight. So OHS collects information using the categories you define here. Hospital, inpatient, and outpatient are generally what we think of hospital, inpatient, outpatient. There's more detail here. Hospital outpatient, for example, includes ambulatory surgery, ED visits, laboratory, imaging services. It includes observation services. It does not include professional services that are billed separate. And the same true for inpatient services. We also collect information for professional services separately for primary care, for specialty physician services. The reason for that is to calculate the primary care spend target performance. And then there's a professional other category that's going to heavily be mental health services, but not wholly. And then we collect pharmacy spending. This is retail pharmacy. So what we sometimes call medical pharmacy, these are infusion drugs that show up in hospital outpatient professional claims. They are not in our pharmacy category. Okay, we can tease that out through the all payer claims database, but not here. Then long-term care, that's a very big category for Medicaid. It's a very small category for commercial and Medicare. And then finally, we have another category. We also collect non-claims-based data from the payers. So this is service payments that are prospective, like capitation, case rates, episode-based payments, performance incentive payments, infrastructure support payments, primary care support payments, for example, provider salaries and recoveries and others. I will note that one non-claims-based payment, it's really a negative payment, is pharmacy rebates. We collect that. We don't put it, we put it specifically as an offset to the pharmacy. All right, so first I'm going to share with you overall what was going on in 2020 by service category. So this bubble graph depicts what was driving spending either up or down. The width of the bubble tells you the extent to which this category contributed to spending going down or going up. So in 2020, this is across all three markets. Pharmacy was the only category spending that went up. I was thinking as I was looking at the slide that pharmacy spending is like the Energizer money. It just keeps going up year over year, pandemic or not. And that's what happened this year, 6% growth in per capita spending for retail pharmacy, retail only. But you can see big declines in other categories, professional physician services and other claims, the largest decline, but everything. If we look at this by market, we can see that in Medicare, everything was negative, hospital inpatient and professional spending, the biggest declines. For Medicaid, we actually had growth in hospital inpatient. It's a little surprising, but everything else declined. Long-term care and professional physician, the largest declines. Long-term care is a huge part of the Medicaid budget. So whatever long-term care does is going to pull the Medicaid budget either up or down. And while the percentage decrease was not large, because it's such a big category of spend, it pulls spending down quite a bit. And then in the commercial, I'm sorry, I missed the commercial market. Oh, no, I did. This, I misspoke when I shared this. I said this was the full market. It's the commercial market only where pharmacy. I apologize. All right, so now let's look at what happened in 2021. Obviously, a very different story. So all the bubbles have moved above the line, and so we have growth everywhere. But you can see that enormous blue circle on the right. Hospital outpatient spending grew 33% in 2021, which is almost impossible to believe. But remember, we've got spending data from 5 carriers. So when we put it all together, there's a consistent story. And while spending grew in all the categories, it was hospital outpatient that was the most significant factor driving commercial spending in this 1 year. Okay, and remember, this is 1 year. I'll just, these of course are unusual years, but I think it's helpful to have a multi-year perspective if we want to look at what's driving spending growth. And we've shown you in the past 5-year analysis using the all-payer claim database. This is just 1 year and an unusual. In Medicare, hospital outpatient and professional spending were the biggest contributors. And in Medicaid, hospital outpatient and professional physician. So hospital outpatient was a major driver in all 3 markets in 2021. And of course, the amount of the growth in the commercial market, as you saw, at 18.8%, was way above what we saw in Medicare and Medicaid. So while hospital outpatient was a driver in all 3, obviously played a much bigger impact in spending growth in the commercial market. Any question about these graphs and what they mean?
Okay.
Is the professional is the professional spending a good thing against the benchmark? Would that be primary care spending? Is that specialty physicians?
So professional spending, we have professional physician, and then we have other professional. So here it's professional physician, which is a combination of specialists and primary care, mostly specialists.
Maurice, School of Pharmacy. Michael, I have 2 questions. One on slide 26. Just to clarify, the retail spend there is net agreements.
Yes.
Okay. And then on slide 40.
Oh, let me comment on the impact of rebates. So In most years, in most states, the effect of rebates is to lower the trend relative to what it would have been gross of rebates, but not absolutely every year. There are some years in where the rebates are larger than they are the next year. And so not always does it lower trend, but this is with an adjustment.
And my other point of clarification on slide 40.
Okay.
Can you comment on the top left bubble, non-claims?
Yes, so what are non-claims? Yeah, so we wondered why non-claims was up so much, because it's a catch-all about a whole bunch of different services. I think the only way we can really understand this is if we do some APCD analysis and dig into it, because this is a sort of a catch-all category for what's mostly small categories of spending. It's possible that we are catching some COVID testing and COVID vaccines here. That's my hypothesis, but we need to look at it more. Paul?
Paul Green, moving to value lines. On slide 39, is the medical pharmacy part of the hospital outpatient center?
Yes, but by and large, there's some that falls in professional physician too. But yeah, I would say more of it is in hospital outpatient.
How about ambulatory service center expense? Is that going to go in hospital outpatient?
Ambulatory service center.
Yeah. So somebody's, procedure in 2020 was done in a hospital. 2021, it's done in an ASC. Kind of where's that?
So if it's a hospital ambulatory surgery, then it's in hospital outpatient. If it's a freestanding, then it's not in hospital outpatient. Okay, most ambulatory surgery, Paul, at least right now, is in hospital, at least in the data that we have most recently.
And one last question, just Jeff, the large claimants, kind of is that this isn't truncated at all?
No, we only truncate at lower levels of analysis, but here the numbers are so big and we're at the whole market that
So this is Jeff Lax, where is it when it's in a non-hospital setting? Because just to give you a different perspective on your last comment, 40%, to be exact, 39%, 39 point something of our organization's total surgeries, total done in non-hospital or non-hospital HOPD settings. So where do the 76?
bill those as hospital claims, Jeff?
No.
They're not billed as hospital claims?
Correct. I think it's like 76,000 surgeries. It's not, I don't know the exact number. It's not insignificant. I mean, it's 40% of total surgeries. So where are those here?
Yeah, Tracy, you remember what category?
Would be non-hospital.
Ambulatory surgical centers.
Oh, it's your claims over a long term.
Yeah, it's probably, I think it's other claims, Jeff. If it's not billed on a UB.
33, 34% of our total joints and hips are done in those centers now, so that's got to be shown up or something. Because we took all that out of the hospital, but for us, the vascular neurosurgery is no longer in a hospital-related entity.
But it's not on the UB claim?
No, it's done in a commercially negotiated rate, but not hospital.
Right, so let us check on that. We might need to confirm with the carriers how they report it.
It's got to be shown up in your.
Oh, yeah, no, it's here. The question is it in hospital outpatient or not?
It should be showing growth, because that's where the ball's going. Right?
Yeah,
That's what things
well, you can see we got lots of growth. I suspect it's in hospital outpatient, but we'll confirm and let you know.
Andy Markowski, National Federation of Independent Business. In which category would we find urgent care or walk-in clinics?
So if they are hospital affiliated, but depends. So Andy, are you talking about the freestanding or the hospital?
Right. Yeah, freestanding.
Yeah. So that I think is in other claims. But if the hospital is operating it, then it's going to show up under the hospital.
In the outpatient?
Yeah.
Oh, okay.
And remember, this is 1 year trend data for sure.
Lori Pasqualini of the Lily Band. I have a question on this commercial slide. You've got a 20% increase in inpatient. That's probably more dollars increase than 33% in hospital outpatient.
Yeah, actually, there's
so I think
more,
that really
there's
is
more spending in hospital outpatient for it than there's.
for in average.
Yeah,
That's still a big number.
mhm.
20%.
Yeah, but remember, it's following a decline, the following prior.
But I think, you know, to me, as a purchaser of healthcare for our elected employees, we can't afford 20% increase in the hospital. We can't afford any percentages are way out of line. And I think the goal here is to figure out how to get these down overall.
Right, well, right, and we're starting with having transparency about what's actually happening, right? That's the starting point, is understanding of what's happening in spending and where is it growing. But you're right, the end goal here is to identify and take actions to slow spending.
And these are gross dollars, not per
So this is growth per capita.
capita. Yeah, that's what.
I just want to offer Jeff and others that I had similar questions about the outpatient surgeries, et cetera. And I think what we can do is we'll follow up with the carriers to make sure that they all have a common understanding, but we can share with this group the instructions that were, there's pretty clear instructions that were provided to the payers when they sent these aggregate sums to OHS about what's included in hospital outpatient and hospital inpatient. So we'll share those, reshare those with the group so you all can see at least the way that the specs were laid out for them.
Thank you, Deidre. If I can offer one other area to look at when doing it, there's a significant amount of patients who previously were recognized as inpatients who are now recognized as observation patients. Significant, but I mean, I think we were at last month. I don't want to say numbers that aren't accurate, in the range of 40–50%. So those patients, I think, are probably falling in the outpatient now, even though they're technically in bed and they're technically in the hospital for a period of time. But we've seen a decline in patients who were previously recognized as inpatients. A massive increase in patients who are recognized as outpatient. Secondly, because we've converted so many services, even in the hospital, that used to be recognized as inpatient, meaning a person who stays 36 hours for a hip replacement, is now an outpatient, even though again they're in the bed in the hospital. That too would be in the outpatient, truly in this outpatient, not in what you and I just discussed. So I'm not sure it's a bad thing that bubble's big actually. In every way, there are some things we should get underneath the observations, because that's a whole other set of concerns. But the fact that so many previously recognized patients are now being paid for and recognized as outpatients at a significant decrease is worthy of studying more in-depthly also. I mean, you know, that bubble, there's a tremendous amount of complexity underneath it that's worthy of looking at.
Okay, so I'm going to share some additional information now. Let me first summarize some takeaway observations on what we should see. So first, spending decline in 2020, we expected that. It's what we've seen in other states. I'll note we have a huge amount of dollars that went out as federal relief payments that don't show up in our analysis. If we had that information, spending would have grown in 2020 because CMS had reported nationally the healthcare spending in the United States in 2020. But that all happened outside, for the most part, of claim systems, and we couldn't capture it from CMS. Two, we had very modest spending growth in Medicaid and Medicare, very high spending in the commercial market. As I indicated, the growth in Connecticut was higher than Massachusetts. So Massachusetts was 11.6%, we're 18.8. I can't tell you what Rhode Island was, but Rhode Island was below Massachusetts. Okay, so that just gives you a comparison. Then across all three markets, outpatient hospital services drove spending growth in 2021, although clearly with more impact in the commercial market. All right, so now I want to share with you total medical expense trends by payer. As indicated earlier, we're not sharing with you trends by advanced network. There are no nefarious reasons for this. The issue is we got a corrective submission from one insurer last week. We simply could not turn around the calculations in time to have them to present to you today, but they will be published by the end of the week. So what we do have is the results by payer. So I'm going to share with you first 2020 for commercial payers, and then I'm going to share with you 2021 for commercial, and then I'll do the same for Medicare Advantage. So in 2020, we've got 5 submitting carriers. 4 out of 5 submitted data that indicate that spending went down in 2020. Only Aetna had an increase. You could see of the 4 that had declines, they were tightly clustered at about 5% decline. Connecticut much larger. We can't explain these variations. We don't know why Aetna was up a little or why Connecticut was down. But overall, clear trend, there was decline in spending in 2020. 2021, very different picture. You can see consistently high rates of growth. For 4 out of 5 carriers, the growth was 17 to 19%. So this was market-wide. Again, we have one slight outlier, United, with only 11%. We can't say why. Medicare Advantage market declines. Again, we see tight grouping at 8 to 9% for 3 of the 4, with United having a slightly smaller decline. And then in 2021, growth between 8 and 11% for 3, and a decline for 1 for Aetna. So it seems like every year we seem to have one plan that looks a little bit different for reasons that we can't explain. But pretty consistent patterns of decline in spending in 2020 and increases in 2021, with the increases in 2021 being much higher for the commercial market than for Medicare Advantage. So if we summarize all of this in this table, we can see that none of the commercial carriers met the benchmark for 2021. For the Medicare Advantage market, 1 did, Aetna. Cigna, that square is white because Cigna does not offer a product or did not in 2021 in the Medicare Advantage market. Okay, so the individual carrier trend is consistent with what we saw at a market level. Okay, now I'd like to share with you the results of the primary care spending target analysis. This analysis looks at primary care spending, both claims-based spending and non-claims-based spending. The definition of primary care spending builds on a collaborative effort across the 6 New England states a couple of years ago, so the states are using generally consistent methodologies. When we talk about primary care for providers, we are talking about family medicine, pediatric and adolescent, internal medicine when practicing primary care, geriatric when practicing primary care, as well as nurse practitioners and PAs practicing primary care. Our definition does not include primary care spending associated with OBGYNs and midwives, but OHS does track separately a broader definition of primary care spending that does include those provider types for monitoring purposes. But when we're assessing performance against the target, we're using the narrower definition. We report the state market and payer levels, not at the advanced network level. And we are looking at primary care spending as a percentage of total medical expense. So same concept of total medical expense that we use for the benchmark we are using here, with one exception. We are excluding long-term care from the definition of total medical expense. And the reason for that is long-term care spending is almost all contained in the Medicaid market. And in order to make comparisons across Medicare, Medicaid, and commercial on a somewhat apples to apples basis, we pull out long-term care spending. Yeah.
You look at, you include, to me, primary care should be assessed as a primary care physician. One, I'm assuming you have all the advanced practitioners in as well. But in addition to that, they have to include urgent care.
So urgent care is a significantly increasing component of primary care services. So when you're looking at primary care spending in total, it's augmenting what we would traditionally define as primary care. And similarly, the shift to advanced practitioners is notable, but I trust that.
No, it's not there. Yeah, there was a advisory group that preceded the formation of this steering committee that recommended the methodology for primary care to OHS in 2019. At that time, they made a conscious decision, and I would say this was, the definition of primary care was greatly debated, Jeff. There were proposals to include mental health services, ED services. The ultimate definition was to define primary care in terms of continuous comprehensive care, and ED visits, urgent care visits were viewed as not part of a continuous comprehensive relationship. And so for that reason, at that time, that advisory body recommended to OHS to not include urgent care.
And I think that was a mistake. It's not the way it works. And it's fully integrated. I mean, it's a crucial capacity to create more access to primary care, is to utilize urgent care and advanced practitioners. It's part of the ability to deliver coordinated care. So I would agree with that. And I would think it's worthwhile looking at it again, looking at the data both ways if you want to, but I would look at it exclusively as well.
What about the question about the parents and PAs? They would be.
They're right.
So that, Jeff, the advanced practice, PAs and parents are included in the record. Yeah, PAs and parents are included in primary care definition.
So we collected data for the same years from the same carriers, also from DSS. The analysis does not include Medicare fee-for-service data. The reason for this is Medicare is unable to report to OHS primary care spending separately from total medical expense. So the only way we can analyze this is through Medicare fee-for-service data that's provided to OHS for the all-payer claims database. And as of right now, we still do not have 2021 Medicare data in the all-payer claims database. So when it is available, we will use that data source to calculate 2021 primary care spend for Medicare fee-for-service. As Deidre indicated earlier, the primary care spend target was achieved in 2021. Overall, there was $1 billion in primary care spending. It equated to $29 per member per month across all markets. The spending grew 10% in 2021. When we look at it by market, though, as Deidre indicated earlier, it looks a lot different. So in the commercial market, spending on primary care declined from 4.2 to 2.9%. That's despite 12% growth in spending. And that's only because the spending for everything else grew more than 12%. So that's why primary care as a share declined. And you can see the commercial market spend is $25 per member per month. Medicaid market, Medicaid spending in primary care is the highest, at over 8%. Spending grew 6.6%, which was above total Medicaid trend. And per member per month spending in Medicaid is $27. So Medicaid is spending more per member per month on primary care than the commercial market is by a couple of dollars. And then last, Medicare. So Medicare spend on primary care is below the target at only 3.5%. That's despite the member per month spending being much higher, $39. That compares to 25 and 27 for commercial and Medicaid. You know, why is it only at 3.5%? It's because Medicare beneficiaries utilize a lot of other services. And so despite greater spending in primary care, there's way more spending on things not primary care. If we look at commercial insurer performance against the primary care spend target for 2021, we see that there are 2 payers that exceeded the 5% target, that being Connecticut and United Healthcare, and the other 3 below. I want to note something here as we look at this information. So when we are assessing performance, we're assessing obviously primary care spending, but the primary care spending is evaluated relative to total spending. So this does not necessarily mean that Connecticut and United Healthcare are spending more on primary care than the other carriers, because the total spending might actually be lower for them, right? We separately have in the report that you all will get on Friday, what's the actual spending per member per month by each carrier primary care, which is another relevant reference point, because the burden of illness of the covered populations is not the same across the line. Some of them clearly are serving sicker populations that have higher levels of spending. We look at Medicare Advantage, all 4 of the carriers were below for 2021. So a couple of takeaway observations. The target was met in 2021, largely because of the high spend in the Medicaid market. I want to note as an aside that the 5% target that was set for 2021 was set back in 2019, 2020, based on an estimate of what baseline primary care spending was. Because the assumption was that the target was not being set far enough in advance for payers to adjust their payment policies to make a change in primary care spending. So we thought that baseline was at about 5%. So we thought, you know, that's to be fair, but as Deidre noted, the target now climbs every year until it gets to 10%. So it's not totally surprising that we came in at where we thought we were at baseline. Significant growth in primary care spending, countered by slow growth in everything else, will be the only way that we get to the 10% target in the 5-year period. Okay, because it's both factors. We've seen if primary care grows double digits, but everything else is growing even more, the primary care spend target isn't going to be met. We need the 2 moving in opposite directions. The 2 meaning primary care going up and everything else growing at a slower rate than primary care. Okay, any questions about the primary care data?
I'm sorry, I do, but I don't know how to raise my hand again.
Go ahead.
Hi, Michael. Thank you for the presentation. I guess one of the things where I struggle to understand, and I'm Susan Millerick, and I'm the patient advocate, so I'm trying to think through all of this from the perspective of somebody who goes for a lot of primary care and sends kids and what have you. So just real person, so take it for what it's worth. But I'm trying to understand what a hospital system's incentive is to promote proper evidence-based primary care to keep people out of hospitals. I still struggle with how the hospitals are going to make the money that they want to feed their employee base and support their patients and do all the things with their healthcare innovation that they're trying to accomplish if they are not filling beds all of the time. So if you take something like chronic kidney disease, you can easily stop the progression of that, which is downstream of hypertension and diabetes, through medication and treatment and management. But then you get into, like, if they progress, they get into dialysis, they get into transplants. Those are big money items. So I'm trying to figure out what the incentive is. And I don't know, Michael, if that's something you can answer, or if somebody, Kathy or Chris or Jeff, could kind of throw in on and help me understand, because that's where I'm lost, is like, what's besides altruism, which I believe they have, what's the financial incentive? Is it just value-based care arrangements and you keep the savings? Like, what is that? What does that look like? Help me understand that, because we want more primary care and we want people to be healthier and we want people to be happier and live good quality lives. And yet people are still going to the hospital all the time, and they're going to urgent care when they shouldn't be. You know, like, what are we doing wrong? And how do we incent the right care at the right time in the right place? That's really what I want to know as a patient.
This is Kathy Solar. Maybe I'll take a stab at it, and then my colleagues here can jump in. So first of all, on the primary side, both for adults and children, physicians are incented to do all the proper things to prevent illness and do health maintenance for their patients. And that is through pretty much every single plan that we participate in. And they're measured against that, and they are rewarded against that. And then I would say secondarily, and I think I speak for my colleagues here as well, our goal ultimately as providers of system care to our communities is to keep patients out of the hospital and provide them with the comprehensive care they need to stay well. And that is our overriding goal. And if hospital utilization decreases, then we generally pivot to growing other services on the outpatient side that will meet those needs at a much lower cost level and keep patients out of the hospital and keep them well. Because our goal as stewards to the community is to keep the community well. That is our commitment.
First of all, thank you. You raised a wonderful question, and you said beautiful context. Adding to what Kathy said, you know, health systems around our state have moved over the last several years to change the way that we are paid and to change the incentives for healthcare. So several years ago, it was an ambition. Today, it is a reality in a number of instances where we have our own insurance products in some instances where we are incentivized for the total cost of care. We also have risk-bearing entities that have been established that can work across in partnership with all the payers to incentivize the health systems to provide optimal care and to strengthen kind of the role and the purpose of the care coordination and the primary care. So certainly the migration away from traditional fee-for-service to risk-based care or outcomes-based care, where quality and results are ultimately factored in how payment occurs, you know, is a crucial migration, you know, that is happening today. You know, to do that, it's taken years and years of investment and infrastructure development and trials and tribulations. It's a massive transformation after a system has been in place, you know, with such great legacy. But there are early results now that are starting to be achieved.
I thank you for that, but I still can't understand why 90% or thereabouts of people with chronic kidney disease remain undiagnosed. Check the APCD, check your own populations. I'm trying to understand what's your incentive to keep them financially, your incentive. You're a money-making institution and that's important, but I get that because you only get better when you make money. But I'm still looking for that financial incentive to stop all of those patients, and in a value-based arrangement where you get a certain amount of money with the diagnosis and you keep it under that, you keep that money. great, but like short of that in all of those arrangements, and that's really only Medicare Advantage, really, I'm not sure it's everywhere yet. Like, how do you make money to keep all these people employed and to run your big buildings and your facilities and your far-flung outpatient facilities if you aren't putting people in hospital beds? And so I'm not sure how to break that. And that's what I'm really struggling with as a patient is like,
Yes, Susan, this is Lou with Anthem.
I think you have hit on the key question. And it kind of is a good segue to our wrap-up next steps. I mean, I think Jeff noted importantly that our traditional payment systems have incentivized volume over outcomes, to your point, and that we're the country's on a path to, trying to change the alignment of incentives in our payment systems. But that really is the next step. So Michael said that, this process is about shining a light on where we are. And I think we've had some really helpful discussions about places where we need to dig deeper in what we've seen in cost trends and explanations that people appropriately want to see for the cost trends that we've observed. And then, of course, the next $64 million gazillion question is what we do about it, and in a way that we can collaboratively come to agreement on that. Continues to support high quality inpatient services, and then gets the kind of outpatient and long-term outcomes that you're talking about. That is, I think, the work before us as a state, and this benchmark initiative is really meant to be the place where you can all come to agreement about what the facts are. Because as long as we don't have the facts before us, the information that we can agree on, we can't get to collaborative solutions. So, Susan, I think you pointed out that the next step is, how do we talk about solutions? I'm going to turn back to Michael if he's doing anything. You're done. Okay. So, anybody want to make any? That was my sort of wrap-up comment.
We got a couple of wrap-up slides.
Oh, go ahead. Next slide.
Hey, this is Lou with Anthem. I don't know if you guys can hear me or not. Just want to.
Go ahead, Lou.
Okay. Jeff talked a little bit about value-based, and certainly this is the road to get there. Susan, to answer your question, it doesn't happen overnight. And there are some really good inroads to starting down a mature value scale, but it's early. There's still a lot more to go. To your point, Medicare has gone a lot further. Commercial, we're just starting on, and then there's upside only risk, or there's upside only value deals, and then there's upside downside where there's shared accountability on all sides, in full for Medicare, Medicaid, upside downside, total cost of care, down to the point of even fully global cap. I mean, those things are possible, but it's a maturity scale on value, and it depends on where you are, and there's a lot more work to do to get there. I think the good news is everybody at the table wants to get there, and that's really been the first time in a long, probably in a long time, that we've all kind of been able to sit down and say we want to get there. Now it's just a matter of how. It's not easy, right? You can't just flip a switch and move to complete mature value overnight. It's going to take time to get there, and I guess that's the answer. There's no silver bullet. It's got to happen slowly over time. And somebody mentioned it early on. It has to be a collaborative effort, or else it just won't work. The good news is I think the collaboration and the desire and the goals are there on all fronts. It's just how quickly can we get there?
Awesome. Thank you.
Thank you, Lou. Anybody else? Okay, we already mentioned that this is the first year of our hospital benchmark for primary care spending target reporting. We do have an obligation under the statute to release a full report by March 31st. We will do that. It's in its bit and polish phase right now, so all that will be posted. The slides from this afternoon's presentation will be available on our website after this meeting. so you can check those out if you want to work some more. And then we will have quality benchmarks that we will start reporting next year in the spring, right after our hospital benchmark. Our first year of quality benchmark reporting will happen. And we, as this group knows very well, we have with Avela and mathematics support, we have been supplementing the phosphorus benchmark work with further analyses from our all-care database to do the kind of deep dive that we need to do to understand some of these trends. So we will continue to do those analyses as for this coming year. We're going to continue to talk about pharmacy spending and hospital spending. I think the next time we come together as a group, we want to talk a little bit more about strategies. We started a couple of subcommittees last year, had some fits and starts, and I think we want to talk a little bit more about process coming up. And are we going to get to review? Okay. So you might have seen in Grace's timeline, another part of the statutory framework for this program is a hearing that we need to conduct by the end of June. So we are in the planning stages now for that hearing. The purpose of that hearing is for individuals or entities that have exceeded the benchmark or contributed to the benchmark performance to come before OHS at a hearing and respond to questions about phosphorus and potential strategies for mitigation. The statute gives OHS a fairly wide latitude about who to call for those hearings. That's a process that Massachusetts also uses in their program. So this will be our first go around. If any entities that will be part of the hearing will be given plenty of notice in order to prepare for that. And then the final phase of the program is a report that OHS is obligated to produce with recommendations by the end of October 1st to the legislature and the public. So those are the three phases this year: healthcare cost growth and primary care, then the hearing, and then the report, and next year the quality insurance in April. From the team at OHS, anything else? Great. Well, I want to again thank you all for coming. We're working on learning how to get back together. It's a little hard when you have to pass the microphone, so we'll continue to think about venues where it might be a little more convenient to have a conversation. And we realize that this is a track for many of you, so we're not going to continue to hold all these meetings in person, but we would like to continue to have periodic opportunities for us to get together and talk about both the findings and the solutions.
Can you talk a little bit about what we said in the agenda? Just wondering if we can get a sense of what the topics will be for discussion next month as our work progresses.
Well, just two comments, I guess. One is about primary care. What are we going to do to move the needle on the commercial primary care payments? I'm hoping that'll be on the agenda. And maybe one of the things that you do when you ask the insurers companies to talk about what their initiatives are to improve primary care payment. So that's one. And then two, we've talked multiple times about alternative payments and the willingness to adopt alternative payments. And we've talked about a project to measure that across the state, so that make an update on where that stands.
Yeah, that should be on.
And just to follow up to the primary care, I think it's important for us to understand the access So this is taking also the Connect Health Foundation. And I know that access is often an issue with primary care overall, so we'd be remiss in not including that.
Representative Cruz, Connecticut, primary care, and access. I think there's no incentive for people.
I totally agree with that comment on access to primary care. Being a physician myself, the issue is we are a line factory to be able to support our practice financially. And therefore, it's a disincentive for patients because they feel like we're not spending enough time with them. They don't want to come, or they rather wait instead of spending 15 minutes to somebody who is in a rush and tell them to stop smoking, just wait and take the meds. So if there was a positive incentive for the primary care clinician and the patients to access primary care, it would be helpful.
So thank you for that, and thanks for the suggestions. I think I have also mentioned that we have, the two subcommittees that have done some work on pharmacy spending and potentially preventable readmissions. So we'll talk a little bit about the work of those two committees, and then we can add potentially some of these topics. I think where we need to do some planning as a group about how to tackle these things one at a time. We can't boil the ocean here. So I think looking at the underlying drivers and talking about evidence-based strategies will be important. So. All right, with that, we're done. Thank you, everyone, again. Very nice to see you all.